So basal cell carcinoma is the most common cancer in humans. Right now at Johns Hopkins, we have a clinical trial going on for patients where the basal cell has done all sorts of damage to a part of the person's body. Our study is showing that if you use the medications in a very specific way, you can increase the likelihood of success by 20 or 30% compared to what is the usual standard.
Hi, welcome back to Glow Talks with Jess. I have a very special announcement today. We are celebrating our 1-year anniversary of the start of Glow Talk, and I would like to take this time to dedicate this podcast to my late husband, Rudy Ernst. We miss him very much, but I have a very special surprise. I'm here today with Dr. Evan Lipson of Johns Hopkins. He worked with us over the course of Rudy's, battle with cancer. He is the associate professor of oncology here at Hopkins, and we're here in Baltimore taping in his conference room. So thank you, Evan, for having me. I'm just so honored to have your time and to be able to share with my viewers some of our journey and your specialty, and just raise awareness and help to educate people on your research and why it's important and the future of immunotherapy.
Well, thank you for inviting me to be here, and I'm delighted to talk about all of those things and share my excitement about the research that we're doing and how we can move this field forward together.
Oh gosh, I'm honestly I'm just over the moon right now. So, well, let's start with a little bit about immunotherapy, because I think a lot of people aren't really aware of what it is and how it's different than traditional cancer treatment.
Sure. So immunotherapy is one of my favorite topics, and it's the focus of most of my research. And essentially, immunotherapy is based on helping somebody's own immune system get ramped up, get activated, so that the immune system can start to see these little tumors cancers that form. In my case, it's cancers that form in the skin.
Right.
In other physicians' cases, it's colon or breast cancer or lung cancer, but helping the immune system to see those tumors to start to form and to begin attacking those tumors before they can cause big problems.
So essentially, it's not the medicine attacking, it's the medicine helping your own immune system.
That's right.
Take care of it.
That's right.
Okay.
So we like to picture the immune system as a car that's sitting at an intersection. And you're asking the immune system to get going across that intersection and run over those cancers. The trouble is that there are these little traffic lights that are stopping the immune system from being able to get going and go through the intersection. The medicines that we're using are these green lights. They're turning those traffic lights from red to green and allowing the immune system to get up off the couch and start attacking cancers. And the ways that we're investigating the immune systems are by trying to turn each of those little traffic lights from red to green. Some people...
Rudy would love that.
Yeah.
In his Tesla plaid.
Right, and we used every immune green light turner in Rudy that we possibly could.
Yeah.
And a lot of our research involves trying to understand who needs which medicine and why. And if we've used all of our medicines, what else is there out there to help patients' immune systems get up, get moving, get activated, start killing cancer?
Yeah. Well, I mean, what I thought was really incredible was, towards part of his battle was when we, saw there were many tumors, and, the immunotherapy medications he was taking weren't turning the lights green, right? Yeah. You gave him a couple of medications that were taken in a pill form. And I mean, it was literally miraculous to see him within 5 days, bounce back like that. And at the time, I know you told us it was just a bridge, or a Band-Aid necessarily. We couldn't expect or know if it was going to be a long-term solution. But I mean, it really was incredible. Really incredible to see him come right back from those medications you gave him.
Yeah. So. Some of those therapies that we give, especially the ones you're talking about, work for a brief period of time, 3 months, 6 months, 9 months, something like that. And then the tumors sort of evolve to stop being sensitive to the medication.
Okay.
So a lot of those therapies are terrific for the period of time that they're working.
Right.
And the trouble that we run into, of course, is that when they stop working, the disease grows like it was never under control to begin with.
Yeah.
So we're trying to understand how we can turn that around so that we get these durable long-term responses. Yep. Tumors are not under control for 3 months or 6 months, but rather years, 6 years, 10 years, et cetera.
Mm-hmm. Well, and with Rudy's initial bout, right, he did have a tumor in the back of his neck that, we had to go in and really remove a lot of his tissue and remove margins. But I mean, it gave him an extra 5 years in addition to the immunotherapy that he had taken for the 1 year right after he had some of that, some of the tissue removed.
Right. That's a great point.
Yeah.
It's worth kind of drilling down on that.
Yeah.
So his initial spot, the place where it all began, was back there, you're right, on the back of his neck.
Yeah.
And so one of our surgeons went in there and took that out, along with some tissue surrounding that area. And whenever somebody has an operation like that, not just for melanoma, but for other types of cancer as well, the question that always remains is, did we get every last cancer cell?
Yeah.
Or are there little cancer cells floating around in the body that we just can't see and could not be removed as a part of that surgery?
Right.
We are left with that question over and over and over again.
Yeah.
And so in his case, we said, well, there's a reasonable chance that despite having had that excellent surgery, there are still little cancer cells floating around in your body someplace. So let's give you some medicine to see if we can sort of mop up the rest of those little tiny cells. So we did, and that may have worked for a time. It may have kept things at bay for a time. But part of our research involves understanding on a molecular basis, on a microscopic basis, can we detect whether those cells in fact are in somebody's body, right? Some people have that surgery and there is no more cancer left.
Right.
They don't need any more medicine because the surgery has removed every last cancer cell from the body.
Yeah.
Other patients, it's the opposite. Same surgery, but a cell or 2 or 10 or 100 escaped. And they're floating around, and if you wait long enough, they will declare themselves. They will come back. They will grow somewhere in the body.
Yeah.
So we are working on finding ways, usually blood tests, but finding a way to understand, well, on a molecular basis, is there cancer left behind? If so, we give somebody therapy. If not, we leave them be.
Yeah. No, and I mean, he did great after that initial process and the initial immunotherapy, but apparently there were some molecules left behind that we didn't know about, right? But I could really, I mean, honestly, and I've said it over and over to everyone who I speak with, like, I thank you and your team and just your love and support and care in the process of it, and being on the side of like the caregiver and assisting the patient, family of the patient. I felt that Rudy was just very well cared for. And despite the outcome, like, I believe very strongly in your research and what you're doing.
Thank you.
I mean, based on what I saw over the last 7 years, like, how do you see immunotherapy as far as like future cancer treatment? Like, how is that going to fit in, let's say, in the next 10 years? Like, what's your research showing?
Great question, which I will get to, but I wanted to say one thing about your comment a minute ago. So I think part of the reason that the partnership with Rudy and you and my team worked so well was because we were exactly that. We were partnered against this common foe, if you will. And we would have discussions, and you guys would bring things to the table, and we would make suggestions and recommendations, et cetera. But I think all along we felt like we were working against the same sort of common enemy, if you will. And I think that's important in partnerships with any physician team, et cetera, but particularly in oncology, where the stakes are so high. And we feel that too. I mean, we often feel where the strongest partnerships occur is when we are really sort of moving all in the same direction. And that happens when we have great communication. And you can have open lines of communication and say, look, this is my concern, this is my fear, this is my recommendation, this is what I want to do, this is not what I want to do.
Right.
That was always helpful.
No, that was really helpful. And Rudy was very adamant about, like doing whatever he could.
Yeah.
So I was always very proud of him.
Where do I see immunotherapy fitting in? Well, so immunotherapy has been a real game changer, not just for patients with melanoma, but for lots and lots of different cancers. Breast cancer, colon cancer, lung cancer, you name it. The list grows and grows and grows. Part of the reason for that is because when I said the immune system before is like a car at an intersection, that intersection is sort of a common denominator, meaning that intersection exists not just for skin cancers, but the immune system can kind of see anything.
Right.
It sees viruses, it sees bacteria, it sees fungus, it sees cancers, sort of any kind of cancer.
Yeah.
So it hasn't been an absolute game changer for all cancer types. We've definitely got a lot of work to do. Pancreas cancer, for example, really hasn't had the same successes that melanoma has.
That's a tough.
Prostate cancer, same thing, not quite the same. But a lot of the cancers out there are changed markedly. Patients now are surviving much, much longer because of immunotherapy.
Yeah.
So I see it fitting in as a key element in a lot of treatment pathways for many, 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 many patients.
Okay.
I think a lot of work has yet to be done in two camps. So the first is in patients where they have a specific tumor type where we just have not had so much success. Pancreas is a good example of that. And then the second is where you've got a tumor type that is sort of typically responsive in a good chunk of patients. Melanoma is one of those. But there is this other portion of patients that, despite having melanoma or some other type that's traditionally responsive, you just don't see that same bang for your buck.
Yeah, well, and I think Rudy also had some kind of genetic predisposition, or
Yes.
it was a specialty case.
Yes,
you know,
that's true. We see that in about 5 to 10% of people where they've got this gene that is being passed down from generation to generation to generation. And you're right, it predisposes people to develop various tumors.
And have it like aggressive.
Yeah, some of them are harder to treat. Some of them show up when patients are younger than what we typically see.
Yeah, I know you've told me you've had younger and younger patients.
Yes, that is true.
That's just the tough part right now.
That is true.
You know, looking at the thing as a whole, right?
Yeah, that's true. Then not only is it skewing younger in some cases, but also the incidence is rising. So we're seeing more and more and more cases of not just melanoma, but lots of different types of skin cancer over the last, say, 50 years.
Yeah, no, it's tough. I mean, do you think that's because of just oxidation, sun exposure?
Lots of theories on that. I don't think anybody has an absolutely, spot-on answer there. We do try to encourage safe behaviors where we can. So we say no tanning beds, we say good sunscreen, we say seek shade, we say long sleeve shirts, wide brim hats, that sort of thing.
I mean, I think people just forget that our skin actually is the largest organ in the body.
Right.
Like, nobody really thinks about, I got to care for my skin. You
Right.
know, they're thinking about their brain or their liver or whatever, but it's a thing.
It is. That's
so,
true.
Sunscreen.
Yeah.
Wear it every day, So you answered a couple of questions that I already had, but what kind of improvements are you seeing? I mean, I know that you were mentioning that immunotherapy is helping to elongate, somebody's life expectancy who had been diagnosed with cancer. Any other, positive outcomes or things that you're seeing as a result of patients taking immunotherapy?
Well, I'd say two things. You're right, the survival is better. So if you look back 20 years prior to the advent of immunotherapy, the likelihood that somebody would be alive at 5 years who had stage 4 melanoma was about 10%, give or take. These days, the likelihood somebody's going to be alive with stage 4 melanoma at 10 years is about 50%.
Okay.
So we're much better off in terms of helping larger portions of the population than we were, say, 20 years ago.
Yeah.
Like I said, there's still that portion of the patients that just don't respond in the same way. So they need help, and we're working on figuring out how to further boost immunity so that you can get, more bang for your buck in a greater percentage of patients, for sure.
Yeah.
The other thing that we really need to focus on is helping the immune system to only attack the cancer and leave the rest of the body alone. So that is becoming a bigger and bigger deal.
Okay.
So right now, one of the tricky bits of using immunotherapy is that sometimes you activate somebody's immune system and it comes off the line with a vengeance.
Okay.
And it starts attacking parts of the body that have nothing to do with cancer.
Okay.
It attacks the joints or the skin or the lungs or the brain or the liver, the kidneys, thyroid, whatever.
Yeah.
And sometimes that can be dangerous. The immune system can do a lot of damage. And so we are working to help the immune system attack just the tumor and leave everything else alone. That is a big challenge.
So but I think overall, is it better than chemotherapy? Because I know that chemotherapy and other cancer treatments like basically do the same thing, right?
It's a good question. You're right. There's the difference between standard chemotherapy, which at its core is sort of a poison, cell poison, and immunotherapy, which is a little bit more directed, although, as I said, it can cause some side effects.
Sure.
I think typically when people think of chemotherapy, people picture sort of a person with their hair that's fallen out and they're sort of nauseated and vomiting. And exactly. In bed for 3 days. So you're right. The feeling, the overall sort of picture of a person who has gotten chemotherapy versus somebody who's gotten immunotherapy, those pictures are very different. So is it better or is it worse than chemo? I don't know. If you ask somebody who's gotten a terrible toxicity from immunotherapy, I'm not sure they'd say it's better than chemotherapy.
Sure.
Is it different? Absolutely.
Okay.
I think we're learning how to sort of rein in the effects of immunotherapy so that it only hits the tumors and leaves everything else alone. So we're getting better at sort of precision medicine.
Yeah, no, that's wonderful. I do believe that it is going to be more of a cutting edge and progressive treatment for cancers of many types, just like as you say, which leads me to ask now, as when we first met, that clinical trial, you were just having it, like it just became FDA approved once Rudy saw you and he started his treatment with immunotherapy. And I know since then you've developed other immunotherapy medicines. I mean, how many clinical trials are you running a year to develop new treatments that are effective? Like, what does that process look like?
That's a great question. Yeah. So the clinical trials are really at the heart of what it is that we do.
Yeah.
So when patients agree to participate in a clinical trial, first, we are tremendously grateful for their partnership. And we really base a lot of our standard therapies on results from these clinical trials.
Yep.
And without these trials, we wouldn't have any idea what the efficacy and safety profile of these medicines are. So we're tremendously grateful to patients and families who participate in these studies.
Yeah.
You're right. In Rudy's case, we had just received FDA approval of a particular drug combination.
Yep.
We had been testing that since 2013, so it was sort of a decade in the making.
Yeah.
Almost.
I mean, it takes a long time, right?
It does take a long time. You need to test it in hundreds and hundreds of patients to really get a sense of what the medicines can and can't do and how safe they are and what the toxicity is.
Yeah, collecting data.
Yeah, collecting data. And, the more data you have, the better sense you have of like, what are my odds of responding this way, or the tumor's going to shrink or not, et cetera, et cetera. So we run, I don't know, probably 2 handfuls of trials each year in various capacities. I think the larger scale, though, is that we are a part of the bigger melanoma community.
Yeah.
Worldwide, really.
Yeah.
So there are these big academic institutions like Hopkins, like Georgetown, like the University of Pennsylvania, like Harvard, like UCLA.
Yeah.
And together, as sort of a global community, we kind of have our finger on the pulse of who's got which trial and where they can be found. So we often will send patients to like a sister institution because they've got a specific clinical trial that's good for a particular patient.
Right, because you have to like kind of come in with a questionnaire for the patient to see if they're even it would be a viable solution for them.
Right.
Right.
You have to know enough about the patient to understand what the disease looks like and what the patient looks like, and then you kind of have to know what the landscape is out there and say like, all right, based on your specific situation and what the trial landscape is, I think you need to be at MD Anderson in Houston to get this specific trial. Yeah.
Well, and that was actually answering my next question, which is, how important is it to have a collaborative process, with this community, right, of trying to find solutions for cancer?
Vital.
Yeah.
Vital. Yeah.
Well, and you're internationally recognized, your work, and I know that you're traveling all over the world, speaking on this. So.
Yeah, we are fortunate to have, like I said, this tight-knit skin cancer melanoma community across the globe, and we lean on experts who, focus on one specific little tiny niche of the drug development, landscape to say like, all right, we have a patient who has XYZ. We need some expertise in this area that you're investigating. I think for all of us, we feel that way. We all feel like our colleagues are vital in the development of new drugs.
Worldwide, honestly, cancer is just such a terrible, tragic, thing.
Yeah.
Like finding a solution, I think, for all of humanity is paramount.
Yeah.
You know?
Yeah.
So tell me a little bit about how could, let's say, if one of my viewers finds themselves being diagnosed with melanoma or other cancers, like how would they go about getting into a clinical trial? Like, what does that process look like for a patient?
It's a good question. So we recommend that patients reach out to a subspecialty team.
Okay.
So somebody who kind of eats, sleeps, and breathes whatever the tumor is that we're dealing with. Most of the time that happens at the bigger academic centers, but I mean, certainly we have colleagues in community oncology settings, local oncology settings, where they are absolutely qualified to, treat somebody on a subspecialty level and enroll them on clinical trials. We're happy to involve ourselves in those patients' care and sort of, share the care among their local oncologists.
Yeah.
But getting involved with a team who really knows what the treatment landscape looks like is key.
Okay.
You want somebody who can help you think like 3 steps ahead and say,
Okay.
you participate in this trial, that means that you're going to exclude yourself from doing trial B, C, and D.
Right.
You want to keep as many doors open as you can, but also sort of really focus on what's going to be effective.
Yeah. No, I think we started first at Shar in Shar Cancer Center in Falls Church, and did a little more research. And my brother-in-law Patrick found you online, and we inquired like directly. But it was that case. Like once Shar found out that like, hey, you want to go into immunotherapy, this isn't going to work for you anymore. And you can't like do everything.
Yeah,
right?
and I credit Dr. Jang and Chelsea Stahl down there at Inova. They send patients to us frequently, and we send patients to them.
Okay, yeah.
And so when you say, we don't have a clinical trial that's right for you at this moment, but Dr. Jang does down at Inova in Northern Virginia. Yeah. Let's head down there and have a consultation.
Well, and I just love that this area, the whole DC metro area, that we just have so many amazing resources, medical resources here. I really am so thankful for that. And that's one of the benefits of living here.
It's true. If you live on one of the coasts or in one of the big cities, Chicago, whatever, Houston, you're right. You do have access to these like big academic, sometimes more than one big academic center doing a lot of these trials. It is more challenging for folks that live in faraway places. Yeah. We are working on that. We are trying to use both telemedicine and sort of shared coordinated care to help facilitate, cutting edge care for folks that live 300 miles from a big center like that.
Wow. And I think nowadays, I mean, in our modern tech society, it's becoming easier, right, to facilitate that.
That's true.
Which is great.
Yeah, that's true.
Oh, that's so amazing. So I wanted to ask a little bit about the role that patients and families can play in cancer research and advancement of finding solutions for cancer. Like, what have you seen that works?
Great question. So I would say 2 things are really vital there. So one is, like I said before, when there's the opportunity to participate in a clinical trial of any kind, we are tremendously grateful when patients and families generously say, yes, we'd like to participate. Even if participating in that trial may not help us at this moment, it has the possibility of helping people that come after us. Yeah. Sometimes that means giving an extra few blood samples. Sometimes that means getting an experimental medication that we think maybe could help you as the patient, but also will help us understand what this medication can and cannot do, which could help people who come after you. Yeah. So that's one, is participating in studies that we've designed that have good science behind them.
And Rudy believed in that very much. I mean,
Absolutely.
He wanted to donate tissue. He was apt for coming in to give blood, do scans, like all of that. So, and I'm thankful because I think some of those medications you gave him at the end were as a result of, some of the tissue that he donated.
Well, so you're right. So some of the medications that we gave him at the end were a result of research that had been done by my colleagues in the past that demonstrated that the specific genetic issues going on with him might have responded to these meds. And in fact, they did. It did.
Yeah, no, that was really amazing.
Yeah, for sure. The second is that philanthropy is key in a lot of the research that we do.
Yeah.
So a lot of philanthropy that we get helps with what we call seed funding, which means somebody on our team has a really good idea about testing what could be a novel treatment.
Okay.
And you use a little bit of seed funding, sometimes from philanthropy, to do a little bit of science based on this idea that you've come up with that could say, all right, actually what we thought of as a hypothesis turns out that holds water.
Yeah.
We've done a little bit of science on it, and that holds water. So let's build a clinical trial around that. And this happens time and time again. I'll give you a little example.
Okay.
Right now, we have a clinical trial looking at immunotherapy for patients who have advanced basal cell carcinoma.
Okay.
So basal cell cancer is really common.
Yep.
In fact, it's the most common human cancer out there.
Yeah.
And there are these cases of unfortunate folks that get these really, really big tumors. And so there are some standard options out there for these patients that have these terrible tumors. Our hypothesis a few years ago was that if you use these immunotherapies in a little bit of a different way, it might be more effective than what is currently the standard.
Out there, right.
So our clinical trial, which was based on this hypothesis and sort of tested using some philanthropic dollars, started a few years ago, and we, it turns out, are right. What we're doing now in this trial has improved the rate of success over and above what is sort of used clinically now as standard of care. So we'll know more as the trial matures, and we're hoping to present some data maybe later this year about this study. But that's a good example of a hypothesis that we were able to test based on some philanthropy that is now a formal clinical trial that we hope will be successful in helping people respond better to some medication.
Yeah, no, I mean, it's obviously very important to me. Last year, you were kind enough to come to our golf tournament, and we did raise some money last year for that, which I was so thankful. I wish we could raise more, but here we are again. And luckily, your admin staff were so nice to design and put together a website where my followers and friends and family can donate directly to the site. On behalf of, Rudy and to your research directly here at Johns Hopkins. So we have the link and it's ready to go. I'm very excited about, doing another push to raise some money for you guys. I really believe in what you're doing. And, and I know that, your struggle, I think also in life, as you shared in your last podcast about your mom passing of cancer, like it just touches close to home. And it's the same for me. Like if I can have a push and do something for the greater good of others so they don't have to go through what we went through, like to me, then it's like I've accomplished my work here on Earth.
You're right. Yeah, I feel the same way. When I was a kid, you're right. My mother passed away when I was 13. She had cancer. Thank you. She had a cancer that we couldn't really define until I was well into adulthood and into medicine. And at the time, I remember thinking that we had this big book in our home that was sort of said, "Cancer," was the title of the book. And I thought to myself, even if you read that book from cover to cover, you still wouldn't know what to do, how to treat somebody. So you're right. I mean, the satisfaction, the fulfillment that I get from doing the work that I do is trying to make headway, to really get on the cutting edge and to help families, yours, mine, do it better.
Yep, that's right. We're here to make this planet better.
Yeah.
So, well, listen, Evan, this has really just been such a pleasure. I'm just so thankful and honored to have you here and share with my viewership about some of our, experience together and what you're doing to help the world. I'm very happy and thankful, and I'm ready to continue.
Well, thank you.
To continue the endeavors.
I value your partnership, and I'm so grateful for you and your viewers, and it's really just an honor to be here. I appreciate you including me.
Yeah, so I know that it's kind of tough to get in touch with you, so I'm not going to suggest that everyone's going to get in touch with you. But if you guys want to, make a donation, the link is going to be in our description box. You'll find it also all over my social media. And And we're going to leave Dr. Lipson to do his important work here at Johns Hopkins. And, please feel free to like and subscribe and share this podcast with anyone that you think would benefit from hearing more about cancer research and melanoma in particular. So thank you all for watching. You can find me on YouTube, Apple Podcast, Spotify, and you can also find me on Instagram on my personal page, Jess Ernst, and Glow Talks with Jess. And I will see you in the next episode. Thank you for joining, and happy anniversary to Glow Talk.